Let's see. Nice. Welcome, everyone. I'm very, very honored to have our guest today. She is connecting with us from Ohio. She is a board-certified GYN, a gynecologist. She's also a specialist in functional medicine and regenerative medicine, and a professor at Northeast Ohio Medical University. And she has founded Revitalized Medical Group, her functional gynecology practice. And she's also known as the Hormone Guru, a functional GYN academy, if I can call it that way. She'll correct me when she gets online. But it is a space filled with information and academic content for us health professionals that I will suggest you check out at the end of this interview. So without further ado, I am going to ask Dr. Tara Scott to join us. You can wait while I pin her. Let me see. I'm not very good at this, sorry folks, but that's it. All right. I have co-hosted you, Tara. So we can all see you. Welcome, Tara Scott. Welcome to this interview. I cannot hear you. Do you hear me? Let me see if you're not muted. Let me see if I took my headphones off. Apparently you're muted. Can you text me through the chat? You're not muted. I don't know what's going on. Hold on.
How about now?
Yes. Awesome.
Okay. So every once in a while I have an external microphone, and every once in a while when someone goes to record, then it knocks that out. So yes, sorry about that.
Yeah, it happens to me too. Yeah, it happens to me too. So Tara, tell us, how are you doing?
I'm good. It's cold up here right now. We're in our winter, so
yeah, right here it's very hot. Paraguay is very, very hot.
yes.
So as you know, Tara, this is going to be recorded for a Spanish-speaking platform in which we upload all these interviews and academic information. It's for health professionals in Spanish in functional gynecology. So I'd like you to tell everyone about your own Latino background, which is very interesting.
Yes, so I was born in the US, but my mother's Puerto Rican. She was born and raised there, and she came to Ohio to get a graduate degree. My father is from India, and he came to Ohio. At that time, it was the rubber capital of the world. So he came to get a PhD in polymers and worked for the rubber companies for a while. So because English was their second language, we didn't really speak much Spanish at home, although I identified more with the Spanish culture. And then when I was about 13, my grandmother lived with us for about 5 years. So we did speak some Spanish. And at one time I was very fluent. I never learned the medical words though. Yeah. So I have a 355-day streak on Duolingo. I've been practicing my Spanish because I'm speaking in Mexico in April at Integrative Functional Medicine Conference, and I'll be speaking in English, but I at least want to be able to, I can read it much better than I can speak it, and I can understand it. I don't usually tell people I speak Spanish because then they speak way too fast.
Yeah.
But I'm pretty good at reading it. I went about 10, maybe 15 years on a mission trip in the Dominican Republic and performed surgery, gynecological surgeries. And so I could read the ultrasound reports in Spanish and the pathology reports, but I would talk to the patients in my Spanglish, and they couldn't understand me, but I could understand them. So I still needed a translator. So it's definitely something I want to get more fluent with again. And I feel like doing it every day, it really is helpful, but I've never learned the medical words.
Yeah.
So.
It's actually hard for us to, when I went to the States, I had to get used to all the medical terminology as well, because it's not something you use on a daily basis. So you kind of have to get used to it. So it's
Mhm.
great that you're learning. I'm very honored because most of my English speaking guests on this platform, they're like, I should brush up on my Spanish, because you speak English, and how come I'm never took the time to learn Spanish? And it's so nice that you're learning. It's useful. It's a useful
Yes.
language. Yes,
Yes.
just like English is. I think it's very useful. All
Well,
right,
a lot
Tara.
of the world speaks
I
Spanish, so
know.
yes,
Yes. So
yes.
Tara, it's we can cover so many topics today, but one thing I'd like to focus on is estrogen dominance. The people watching this interview are familiar with estrogen dominance. They have already been introduced to the topic, but my belief is that estrogen dominance is something that we've never been properly taught in residency and maybe in postgraduate courses. It's something that has become so daily, in our practice. We see it all the time, and yet we have not been instructed on how to evaluate it, how to treat it, or we've been giving, these reductionist answers, such as, just use contraception for this. And I think we should approach this with more tailor-made hormone treatment. So I want to ask you about how often do you see estrogen dominance in your daily practice, and why do you believe it's become so common these days?
I mean, that's a great question. And if I just back up and say, I'm a traditionally trained OBGYN and we weren't taught anything about it. I mean, we were taught how to get someone pregnant, someone deliver their baby. I could cut out a baby in a minute in an emergency C-section. But then once someone's done with pregnancy, and we really weren't even given that much menopause, now there's a little bit more focus on menopause education. But from those years of between done with fertility, like not trying to get pregnant until menopause, there's nothing for patients. And so the standard of care is don't monitor hormones. It doesn't matter because they're only there to detect diseases, tumors, and problems. So anything in between, like an imbalance, is not going to kill you. So our traditional counterparts, I mean, they will still say there's no such thing as estrogen dominance. If you look at the literature for fibroids, endometriosis, breast cancer, all of them will designate estrogen drives that pathology, estrogen out of balance from progesterone. And so we know that in the normal menstrual cycle, the follicular phase, the estrogen is produced by that developing follicle. And after ovulation, the corpus luteum produces progesterone. So what we see, and it can happen, it's very common in perimenopause because poor quality follicles, an increase in an FSH, right? So more follicles, and it's more common to have spontaneous twins as you age because the increased FSH, so you have more estradiol. But there's other things that are making even younger people affected nowadays. It's endocrine disruptors in our food, in our environment, plastics, phthalates, and our cosmetics. That, number two, just the food that we eat is bad. Sugar and alcohol affect estrogen. And then, we were never taught about estrogen detoxification. And we were taught about cytochrome P450 and liver detox, but never in response to hormones. And so, again, if you talk to a traditionally trained doctor, they'll say, don't test estrogen metabolites. What's the point of that? But I think that's a huge thing in my practice. That was a game changer that we missed the boat. It would be like me saying, everybody should drink 2 liters of water, right? And say you are a marathon runner and it's 80 degrees, which I don't know, are you guys Celsius? So maybe 40
Yes.
degrees.
Yeah.
And you're running a marathon and you only drink 2 liters of water, then you're going to get dehydrated, right? And what about if you're a patient who has kidney failure on dialysis and you drink 2 liters of water? So is water the problem? Is water toxic? Or is it the amount of water and the clinical scenario of the patient, right? That's the problem with estrogen. We all have estrogen, but we all now that we can map the human DNA, we know about SNPs and genetic alterations. We now know with estrogen detoxification, what affects it, what slows it down, other medications, diet, genetic predisposition, toxins. So what I find is people can be more estrogen dominant either because of their genetics, because of what they're eating and what they're doing and their lifestyle changes, and just because of their ethnicity, not necessarily ethnicity, but that they just make a lot of estrogen and they don't make a lot of progesterone. So there's a lot of different things. And add to it now, especially after the pandemic, is stress, how stress, it accentuates all that. It slows down estrogen detox. Cortisol affects everything. It can essentially cause a decrease in progesterone, not directly, but effectively.
Yeah.
So we're seeing more and more and more patients. And I probably see more patients that are younger than are in menopause right now.
And also like you said at the very beginning, the underlying cause of so many GYN diagnoses, right? Like endometriosis, even polycystic ovarian syndrome, everything has this estrogen dominant underlying cause to it. And how come we've never been taught to manage this in a proper way? It's quite alarming actually, because it's so common. And now we're trying to rethink what's going on with our patients from a biochemical standpoint. Like you said, the detoxification pathways are very important, and they should be studied in most of our patients. And what has happened to me is that in my menopausal patients, the background of estrogen dominance really kind of it really outlines how I'm going to do the hormone replacement therapy in that patient. We'll cover that later on in this interview, but I think it's very, very important for us to consider evaluating estrogen metabolites, evaluating the whole estrogen pathway in our patients, and also to just keep in mind when it's going on. We've just never been taught to learn, when it's going on and when it's not going on. And it's going on most of the time. So like you mentioned, women are exposed to all these toxins on a daily basis from cosmetic products, especially, that we might not introduce in the interview, right? So when we evaluate these patients, I want to ask you, what kind of things compose your basic toolkit when you want to assess estrogen dominance, when you want to evaluate your patients? Like, what things we should not leave out when we want to make sure that patient is going through estrogen dominance?
Right. And so part of the fight that we're fighting also is this issue of testing hormones, right? And so we're also told by our traditional counterparts, don't test hormones because they vary too much. But if you look at the protocol for male testosterone replacement, the protocol is test hormones, treat hormones, and retest and monitor. Even the protocol for transgender hormone therapy is test hormones, give hormones, monitor hormones. But what is the protocol for women? Don't test, give hormones, don't monitor. So when we're talking about doing blood testing, nobody argues to do blood testing for the diagnosis of PCOS, right? Everybody says, do blood testing. What are we looking for? We're looking for high insulin. We're looking for high testosterone in the blood. And, they're not really paying attention to estrogen and progesterone, but that's going to be the diagnosis, right? And abnormal periods and high testosterone and possibly insulin resistance. So we can check hormones when we're talking about PCOS. And if you think about infertility cycles, I was an infertility patient. I needed to take drugs to get pregnant. I went in day 5, day 7, day 10. They checked my estradiol levels. They checked my day 21 progesterone levels to see if I ovulated. So you can check hormone levels then, right, to monitor a cycle, a fertility cycle, assisted reproduction. So I don't know where the disconnect is after that. So in the toolkit, obviously, the first thing we're going to do is take a detailed history, right? We're going to talk to everybody about, what do they eat on a daily basis? And we talk to them about their stressors. I could probably be a little bit better about talking to them about their environmental toxins and the toxicities, if there is any exposure. We have a questionnaire that they fill out that it is addressed on there, but I probably need to be a little bit better about addressing possible mold, and then history of trauma, mental triggers, right? So we do all the history. And then if somebody is still cycling, I always start with traditional blood tests. Okay. I like to do testing around day 19, 20, or 21 if they have a 28-day cycle. Ideally, we're trying to reach it a week after ovulation. So if they're 35-day cycle might be more like day 28. But we check FSH, LH. We have now sensitive estradiol assays that are LCMS. So I like to use that ultra sensitive assay. And maybe in someone cycling, I might use the regular assay because I don't know what it's like in Paraguay, but the cost makes a little bit of a difference to the patient.
Yes, it is here too. Yes.
Okay. So for somebody cycling, you probably don't need the ultrasensitive assay. Somebody menopausal, I would probably use that. And the same thing with progesterone. There's a regular progesterone, and then there's an LCMS, which is the LCMS is supposed to be the most sensitive blood levels. And then we always want to get a free and total testosterone. We also look at DHEAS. Now, if we're going to assess adrenal gland, it's generally not in the serum. We might, if you wanted to check in at cortisol, it had to be at 8 a.m. Some labs will run a pregnenolone, but in generally, you're going to be looking at something like salivary testing or urine testing for those, for the adrenals. So we always start with that. And in somebody who comes in, with estrogen dominance, their general symptoms might be heavy periods, but it might also be weight gain, might be anxiety. So I'm going to throw in the metabolic labs and metabolic panel, complete metabolic panel, a CBC, insulin level, and an A1C. I always like to get the insulin level fasting as well. If it's abnormal, sometimes I'll do it 2 hours postprandial, and then a full thyroid panel, TSH, free T3. We have to do the free hormones because we know estrogen's a problem. And when estrogen's a problem, it's going to increase the binding protein. So getting a total T4 and a total T3 isn't as helpful as getting the free T3, free T4, and checking for thyroid antibodies. So that's generally where I start. If someone's already had serum evaluation, or maybe, I guess if they're menopausal and they're not having periods, I won't do the serum labs because the hormones aren't coming from the ovaries. They're coming from the adrenal gland. So most people have access to serum labs.
Yeah, they do here too. We also have urine metabolite tests here.
What's the lab that you have?
We have access to Dutch tests here.
That's awesome. I mean, it's expensive.
Yeah, it is.
It is an amazing test. So I know Mark, who started the Dutch test, and so I've collaborated on a lot of projects with them, and they're actually coming out with a women's health certification. So I've already recorded all my lectures, so hopefully that'll be available for everybody.
Yes,
soon. Yeah,
that'll be great. Yes, I wanted to dig a little deeper in what you mentioned about trauma. What kind of things do you ask for? What kind of things do you take into consideration within the estrogen dominance scenario?
So again, being traditionally trained, this was not on my radar at all until my family actually had a traumatic accident. And then after you start learning more about trauma, then you start realizing how much it has to do. So, obviously the adverse child event questionnaire, is something that looking at childhood events, because your hormones are so tied to your neurotransmitters and your mood and your mental health. And so if you have a history of trauma and you have, some people respond by fight or flight, some people respond by freezing. And when you're doing that, that's affecting your vagal system and your cortisol and your adrenals. And so that for sure, if DHEA is a precursor to your androgens, that's going to affect your hormones. So if your cortisol is upregulated because you have this history of trauma or ongoing issues, cortisol is high, it's causing inflammation, and it does seem to slow down your estrogen detox. So again, like I said, it probably should be on my radar more than it is. And potentially, I've missed the source of dysfunction in some patients by not addressing that. But now I know it could be physical, emotional, mental trauma,
Yeah. And also in terms of estrogen detoxification, I always, whenever I have to explain how estrogen detoxification works, I usually tell everyone, we've been taught about phase 1 and phase 2 detoxification, and we have given very little importance to what I like to call phase 3, which is what happens in the gut. So, yes. So I'd like you to explain this concept of the phase 3 detoxification. What is the estrobolome, and how can we enhance estrobolome function?
I mean, you're exactly right. So I do actually ask all of my patients about their bowel movements. And it's funny because I just went to my doctor, just like a checkup. He's not an integrative. I just you have to go every couple of years. And he didn't even ask me if I poop every day. He asked me if I had any heartburn, any digestive complaints, but in the review of systems, do you poop every day? I ask people, do you poop every day? And what does your poop look like? You have the Bristol thing. So if we think about the liver having phase 1 and phase 2, Okay, so estrogen, let's think of estrogen as floating around. The first phase one is a hydroxylation, and it's getting estrogen as an intermediate metabolite. Then phase two is methylation. It's inactivating that intermediate metabolite. So putting it in a box, tying a bow, and sending it down a slide to go into your gut to be pooped out. Okay, well, if you're not going to the bathroom every day or twice a day is normal, right? Then the bacteria in the gut, and remember, we didn't even have PCR testing or microbiome when I went to medical school or when I went to residency. So certain bacteria increase an enzyme called beta-glucuronidase. And so if you have too much of that, it's almost like the bacteria can get in, open up the box, and release estrogen metabolites, usually in the form of estrone, which is a metabolite that likes to stimulate growth in the breast and the uterus back into the system. And that's another thing I've seen some of my traditional counterparts saying, your estrogen does not back up from your gut. That is ridiculous. I mean, you go to PubMed and you search that, beta-glucuronidase, microbiome, estrobolome, you get hundreds of articles.
Yes,
So
there is evidence.
Yes, because I just had to kind of to add that into one of the lectures I did. So if you have somebody who's pooping once a week, how are they eliminating their estrogen? Their liver may be working, but if their gut isn't working, or if they have a high beta-glucuronidase, and I missed that in a lot of patients before I started doing stool testing. I'm like, why can I not get their estrogen right? And then I finally did a stool test, and their beta-glucuronidase is through the roof. So, if you're holistically trained, again, it's like the more you learn, you realize the less you know, right? So I mastered the hormones, and then adrenal and thyroid, and then I mastered gut, and then I need to learn a little bit more environment, and then the trauma thing. So it's like all these layers of holistic approaching to patient,
Yeah. It's actually the way I like to teach everyone is I like for them to think of the patient from phase 3 and then phase 2 and then phase 1. They address through the questionnaire, they address how are their bowel movements working. And then you see how maybe if you could get maybe a Dutch test, that would be great to see methylation and how it's working. Or maybe you can just test for homocysteine in the blood and you can address somewhat how methylation is working in their body. And then you look at the liver panel and then you go to the hormones. It's like from down up, right? I think it's the best way to approach a patient with estrogen dominance, and then add to that the trauma, the exposure to chemicals and all those things. So that is your basic toolkit, right?
Yeah. Do you have a problem with a lot of processed food there or not? Because that's a huge problem here, but the diet is terrible.
We do and we do not. It's like it depends on the patient's context. A lot of people have access to someone helping them with the cooking at home, so they can really make homemade meals, and that's mostly the reality in our patients. But still, they are still exposed to chemicals in the environment, and it's still going on. So I think the basic question we should ask to see how the estrolome is working is, like you said, do you have regular bowel movements each day, right?
Right.
At least start by that. And then maybe a stool sample with which you can see how the beta-glucuronidase is working.
And do you guys have functional stool testing available as well?
Yes, we have access to the Great Plains test, mostly everywhere, but it's not it's not cheap, but it's not terribly expensive. The Dutch test, though, it's a bit expensive. I do it in some of my patients when maybe I want to do hormone replacement and I really need to see what's going on biochemically, just to not make the mistake to replace estrogen in a very complicated genetic environment. So I order Dutch tests. I promote Dutch tests in most of my patients, in which it's a delicate hormone replacement situation, So you talked about the adrenals in your menopausal patients and how you always evaluate the adrenals because that is the source of estrogen in menopause. So I wanted to talk about a little bit, how is the relationship between adrenal fatigue, adrenal function, and this estrogen dominance scenario? Are they tied in somehow?
Yeah, so your adrenal hormones all start from cholesterol, obviously. And so way at the right of the steroidogenic cascade, DHEA via androstenedione turns into estrone, and estrone can turn into estradiol with a bidirectional enzyme called 17-beta HSD. So when you are in menopause, you don't have follicles, that the follicle is producing 95% of your estradiol. So most of your estrogen is in the form of estrone that's coming from peripheral conversion. So if you think about a kind of a teeter-totter, a homeostasis of, one side of the cascade, cortisol being catabolic, and one side being anabolic, which would be DHEA, also turning into testosterone. When you have a stressor, and there are different components of the adrenal gland, there's not just one big, it doesn't all flow, right? There's only some components that make mineralocorticoids. You've got your adrenal cortex and the glomerulosa, the three, I don't even remember the three names, honestly.
Yeah.
So when you have cortisol, obviously everything is going to be catabolic, and the focus is going to be at producing cortisol. There is a feedback to the brain saying too much cortisol, don't produce any, or vice versa, too little. There isn't a feedback with DHEA saying we don't have a lot of DHEA. So DHEA is going to be downstream from all the precursors, pregnenolone, 17-hydroxyprogesterone. So when cortisol goes up, it's almost like DHEA will initially go down, but it tries to go up to balance because your body doesn't want to be catabolic for long, right? It can't sustain that. It's the fight or flight to run from the bear, but then you're supposed to kind of stay. And then obviously you're going to be anabolic as you're growing, but as you age, you're going to start being catabolic because we age and we don't build any muscle. So that focus between DHEA and cortisol, that homeostasis, is affected by stress. And then I don't know exactly if it's inflammation or what it is about high cortisol slowing down estrogen detox, if it's actually at the enzyme level, is it at the precursor, the substrate level, is it at the gut level? I don't know, but there exists a phenomenon that, so we'll think about how people sometimes when they skip a period because they're stressed, really stressed. Well, that's more the pituitary. The cortisol is suppressing the pituitary hormone, so there's no FSH. That's more hypothalamic. So I don't know what exactly the direct mechanism is, but whether it's just inflammation, whether it's the fact that estrogen, now we're seeing that it's involved in your immune system. There's studies out there with COVID patients that had estrogen, and they actually gave estrogen patches to males in New York who had COVID, and they did better because estrogen promotes it promotes your immune system. But if you have low estrogen, then you have more of a shift to inflammatory mediators like IL-6 and TNF alpha and everything. But then when you have the right amount of estrogen, then you don't have that shift. So we're finding out more and more about what happens in menopause and perimenopause with those estrogen shifts. So for sure, being stressed. And then, there's the other things like, okay, if you're not stressed, you're not sleeping as well. And then it's affecting your melatonin. Most of the people in the US, if they're stressed, they're eating on the go. They're not sitting down and making their meals. They're either skipping meals or eating too many carbs. So then you have insulin upregulated, and insulin and cortisol are fighting each other, right? Because cortisol wants your blood sugar up, insulin wants your blood sugar down, and then they're starting to fight each other. The insulin's not working. So it's a pretty complex web with it. And I don't know that there is a direct mechanism of action, but stress definitely affects estrogen dominance.
Yeah. And before we used to talk a lot about this pregnenolone steal and progesterone steal, that might have been the mechanism. Now we know that it's a total different pool of hormones. The adrenals and the ovaries have this whole different pool of pregnenolone substrate to produce their hormones. So we've discarded that. So I'm also in that, that search for what's going on with my patients with adrenal fatigue and their cycle disturbances, or their tendency to go into estrogen dominance when their adrenals are not working properly. I still have not found out the right answer. I used to think about this pregnenolone steal theory, but then I found out it's not that accurate. So that's the interesting thing. I mean, we believe things today, maybe when, a year from now, this interview will be totally obsolete. Maybe, I don't know, but it's very interesting to be updated and to think, also to think outside the box. I think that's what functional medicine has provided for me. It's not a symptom oriented kind of approach to
Right.
what's happening with my patients. It's why is this happening? Why is she having, this, why do I see this tendency for breast cysts, and fibroids and endometriosis, or what's the commonality between all these things? And I think that's the interesting thing with functional medicine. We might not have the answers today to this question, but we might in the future. And it's very interesting to start thinking about those things and start moving along, or start doing the research as to what might be going on with our adrenal fatigue patients. And when you have menopausal patients, like we were speaking about, the adrenal function in menopausal patients, when, for example, you have a menopausal patient with hot flashes and some estrogen deficiency symptoms, maybe vaginal dryness and all the things you can consider related to estrogen deficiency, and they have a history of estrogen dominance in their fertile years. How do you consider that when you're going to replace hormones in this patient? What kind of approach do you have with them?
Well, it's so interesting because again, the approach traditionally is just give them hormones. And so first of all, I do like to take a baseline hormone level because sometimes people don't need estrogen right away. You can get hot flashes from low progesterone and normal estrogen. So the first thing is you got to document, do they actually have a low estrogen that's causing hot flashes? And again, cortisol can cause hot flashes. So if the patient does have low estrogen and they have a history of estrogen dominance, think about it this way. If you and I both, get paid and you get paid $10,000 a month and I get paid $1,000 a month, and then we both don't get paid for a month, who do you think is going to have a harder time? Your bills and your mortgage and everything's based on getting $10,000 a month, and now you're not getting any. I've only gotten $1,000 a month. So yeah, it'll be hard, but when you have a lot of estrogen, then you have none, that's a bigger change. So we sometimes see these people with estrogen dominance are more symptomatic at menopause rather than the people that had low estrogen kind of all along. It always fascinated me. How do people have no hot flashes? How do they have no symptoms with menopause? Maybe they had kind of lower hormones all along. Maybe they're balanced, or you're someone that it's the change in estrogen that precipitates the hot flash and the symptoms. So one, you want to document what the balance actually is. Do they need it? And let's just say they do need it. So everybody has that threshold of when they feel best with estrogen, right? And just like weight, we could be the same height, but our body build could be totally different. You could have a lot of muscle mass and your ideal body weight might be different than me. I don't have a lot of muscle mass, So everybody has the set point of estrogen. We just don't know it. If we're fortunate enough to have been working with a patient from 25 on, we might have some data on their hormone levels. So I think it's imperative after the patient's been on what you might call steady state. Let's just say you give them hormones, they feel pretty good. At that point is when I like to do the estrogen detox or the metabolites, because you want to see then, okay, here they're on these certain levels, they feel pretty good. How are they getting rid of it? And so I do make sure after they've been on. I don't find it as helpful to do the Dutch test when they have no hormones. And I think, especially since it's so expensive. So, either serum or even saliva. I feel saliva really shows us what is in the periphery, because your estrogen is coming from the periphery, right? That change from DHEA to estrone is in the fat cells. So I feel, and this is my opinion, that is reflected in saliva when we look at estrone and estradiol. And that might be a better baseline test for someone who has no ovaries.
Yeah. So do you still use estrogen replacement therapy with estrogen dominant patients, but what you do is you install the therapy and then evaluate the detoxification pathway?
Yeah, well, first you're going to make sure they need it, because like I said, just by history, they may not need it. For example, there was another patient that was coming into our practice and she had skipped, 5-6 periods. And then she had a lot of hot flashes. So she came in and she get an estradiol level and it was 84. That's not low, right? Well, in that year when you're still skipping periods and you're not technically menopausal, Well, when she came in for the results, she wasn't having a lot of hot flash. She was like really wanting estrogen. We didn't give it to her. Well, she had a Dutch test that showed it was low, and then she had the blood testing, and now she's like, well, the hot flashes went away. So, they may or may not need it. So we can go by clinical history if it's been a year since their period. I don't make them wait a year if they're really symptomatic.
Yeah.
If you want to look at their serum testing at least. Is serum affordable there?
Yeah, we can do it. Yeah.
So I mean, a lot of times here it's more affordable because it's covered by insurance.
Yeah.
If someone doesn't have insurance here, then it may not be cheaper, but a lot of times we're starting with that. So I like to do some kind of baseline, usually serum, unless they don't have ovaries, give the therapy, monitor the therapy.
Okay. Yeah, I think that's very interesting because I myself, I used to see how the pathway worked and then add the estrogen if it was needed, like you said, and then because I would feel safe doing it, right? And then add the estrogen and then see how it went with a Dutch test maybe later on. But I think it's very useful.
From a cost effective, for the patients, they're paying out of pocket for the Dutch test. And I do think it's a great test, but I've seen sometimes when estrogen metabolites are very, very low. Think about it this way. If you don't have a lot of money and I'm trying to track your spending habits, you're not going to spend. So all of a sudden now you make a lot of money. You might be buying a designer purse and going out to eat more, but you're not going to make those decisions when you don't have a lot of money. Mm-hmm. So the estrogen metabolism is going to look different when there's very little estrogen versus when there's a lot of estrogen. And I've seen that all the time. Yeah. So I like to do a baseline, either serum, mostly serum, sometimes saliva if we need to, or just, theoretically, if someone's really symptomatic, you could test, and then the Dutch is more useful after. Now, if someone comes in and they really have a lot of adrenal symptoms, and I really got to look at that, or they have a strong history of breast cancer in their family, or a big, strong history of estrogen-related pathology, then I don't think it's wrong to start with the Dutch. It just I just try to save it for when it's most effective because of the cost.
Yeah.
Where I live, people, it's in middle America. We're not in an affluent area.
Uh-huh. Yeah, I like this approach. Actually, I didn't do it like that before, but I think it's very interesting. It's very valuable to learn, because it is expensive for people here. So I think it's very useful. And also, you mentioned the other actors in this whole hot flash scenario. When I started doing functional medicine, I learned about, it was not an estrogen deficiency. Not only that. So what kind of things do you look for when a patient comes complaining about hot flashes?
Well, you got to look at their insulin and glucose because that can precipitate the hot flash. Cortisol, absolutely. Even thyroid. I also see a lot of low androgens, low testosterone. And now with that, what we see with the low DHA, low testosterone is the effect of stress. And so, like I said, if you weren't stressed before the pandemic, everybody's been stressed through the pandemic, right? Yeah. And so low androgens can cause hot flashes as well. So that's why we do evaluate all the hormones, and then even alcohol and sugar and all those things that can precipitate it.
Yeah, what I mostly see with the adrenals is that they might be in a place where they're in this adrenal overdrive with high cortisol, or they might be in the fatigue area, like they have maybe a resistance, also high DHEA, like in cortisol a bit low, or maybe the whole full-on adrenal fatigue. I see hot flashes in the whole spectrum of adrenal function, but it's very important. I want us to really, really insist on this, because really here, we've never been taught that hot flashes are anything other than an estrogen deficiency. It's and right off the bat, they just give estrogen to the patient. I see it a lot with my patients. And that was not the problem. They just see a solution because it's maybe associated with vaginal dryness. So they're like, okay, so it's an estrogen deficiency. And maybe it's just a local estrogen that's needed in the vaginal tissue and not the whole hormone replacement. And also with testosterone, I've seen a lot of improvement with my patients because that was what was going on.
The biggest problem I see is when someone either has a hysterectomy and still has ovaries, or they've had an endometrial ablation, and so they don't bleed. And when they start having hot flashes in their 40s, they're given estrogen only, right? If they have no uterus, they're never given progesterone. And so that's probably not an estrogen deficiency in your 40s. it's probably progesterone deficiency. They're not testing hormones. And then we're doing the opposite, giving them more estrogen, no progesterone, because they don't have a uterus, because they think, gynecologist thinks you don't need to take progesterone with estrogen.
Yeah.
It's a problem.
Yeah.
Yes.
Do you always use progesterone when you give estrogen? There have been no cases in which you don't combine both.
That's correct. I mean, you can give progesterone without estrogen, but I would never give estrogen without. Everybody thinks about that WHI where they gave permanent only for 5 years in that population, and there was not an increased risk of breast cancer. If you look at actually the data, it's the difference of less than 1%. But if you look at the Nurses' Health Study, where the WHI arm, estrogen only, was maybe 10,000 people at the most, the Nurses' Health Study, which was observational, it was not randomized placebo-controlled trial, but 122,000 women, and it's something like a 22% increase over the first 10 to 15 years of estrogen only. And then the next, if it's like more than 15, it's up to like a 30 or 40% increase in breast cancer.
Yeah.
Also the E3N EPIC cohort, where observational also, but the people that took estrogen only had an increased risk of breast cancer, and they were 40 to 64. There were 80,000 people in that study, but we're looking at this one study that's 10,000 people that was a randomized placebo-controlled trial with one drug.
Yeah.
It just makes no sense.
We've been like scarred for life by the WHI.
Yes, it's 20 years ago, right?
Yeah.
So it's crazy, but that's what, and I am a member of the North American Menopause Society. I'm a certified menopause practitioner. They are very traditional. I actually got my poster accepted at this year's annual meeting. We talked about, I talk about testing levels in breast cancer, but they are just so stuck on this is randomized placebo. This is the best data. I'm like, oh my God, it's crazy. So, yes.
Totally. And what about adaptogens in estrogen dominance? What are your go-to adaptogens? When you choose to use them, and how have they been working out with your patients? What are your results?
Yeah, so my favorites are probably ashwagandha, although that's a nightshade. So if people have sensitivity, they may not be able to do that. Rhodiola is a good one that works if they have too much or too little cortisol. I generally like blends that are, because they're synergistic. So we have like a supplement that's if your cortisol is high or low, one for just high that would have phosphatidylserine and L-theanine in it, and one that if you're really, really low all day, which might have adrenal gland concentrate in it as well. So the ones that they usually have, for low, if you have a high cortisone, licorice root is going to be good to prolong the half-life of cortisol when it's a little bit lower. But usually Chinese ginseng, eleuthero, rhodiola, ashwagandha, L-theanine. So it's all kind of into one supplement that we use.
Yeah, and what happens to me very commonly is that I have patients that respond better to rhodiola in the morning, and some patients respond better to rhodiola at night. And I've looked for research to back this up, but I know maybe some patients feel sleepy with rhodiola in the morning.
I also saw that it's also dose related. I think it's paradoxical that at the lower dose you have a certain effect versus the higher dose or something.
I've seen that too. Yes. You have to adjust the dosage, and maybe I have patients that feel very energized with rhodiola in the morning, and it has worked out just fine for them. So it's very, very interesting to learn about adaptogens in terms of how they work with hormones. And I want to ask you a last question, kind of related to adaptogens, but do you use sulforaphane and carbinol? Do you use these things to modulate estrogen, or with your estrogen therapy, do you use them as an aggregate to all this?
So I do use them, but I usually want to know their estrogen metabolites before I do it. So, if someone already has in the Dutch test, they already have 80+% of the 2-hydroxy, DIM is not going to add anything to them. If you have a SNP that's upregulated cytochrome 1A1 or 1A2, you already make plenty of that. That's where DIM works, 1A1. Phase 1 is going to be obviously the DIM. Phase 2, sometimes the resveratrol, if you have a 1B1 SNP, which is that red percentage, when that's high, then I might give them resveratrol. Phase 2, if they have slow methylation, then it's more B complex, magnesium, well, magnesium for everything, and SAMe. And then phase 3 is where the sulforaphane comes in, or it's a good adjunct if they already have a 2-hydroxy that's high, because sulforaphane is going to work not just at phase 1. And so you also have, your resveratrol that works at phase 1. And then if the 4-hydroxy doesn't get methylated, it goes down a different pathway, which is peroxidase. And that's where it becomes a DNA adduct. And that's where resveratrol works as well. But sulforaphane, I should be having that on the radar a little bit more frequently. And I also think maybe if you don't know estrogen metabolites, that's probably a better place to start than DIM.
Yeah, I read that somewhere. I've been using sulforaphane lately, and I cannot test metabolites in all my patients. And I sometimes use it for safety. But I've read that sulforaphane is actually what you said. Like, it's a better place to start off and then see how it goes. So I think it's very interesting to see that someone else is also trying that and seeing the results. All right. So Tara, is there anything else you'd like to tell us? Tell us about your academy, and tell us about your Dutch collaboration so that everyone knows about it.
Yes, so we are just rolling out our new mentorship modules because, I speak for A4M. I also speak for another course called LP3, which since COVID, we've been mostly virtual, but we did do our live program in New Zealand and Australia, but we have a virtual kind of beginning hormone program. And then I speak for A4M, which is American Academy of Anti-Aging Regenerative Medicine. So I've been asked by a lot of people, do you mentor? Do you have anything? So we're redesigning it. It's at the drtarascott.com site, where we have, educational modules, which are going to cover this basically, right? Estrogen detoxification, estrogen dominance, thyroid, adrenal, PCOS, breast cancer. So we're re-recording and updating them. And then hopefully we'll get to the point where we can even offer a monthly call so people can bounce test results over, if they have a patient that they need help with, they can, we could do it over Zoom. So that's going to be at Dr. Tara Scott, or you could just watch the pre-recorded lectures and have that information for yourself. The Dutch collaboration is not just me. It's obviously other other providers that speak in the industry. And I'm sure Carrie Jones is doing something. I can't remember some of the other providers that they're doing. So
Debbie
it's like
Rice. I've seen her lectures too.
Yeah, so that is, I just recorded last month. I don't know when that's going to be up, and I don't know if that's going to be a nominal cost or free. I think I haven't seen the details, but they're trying to get that up this spring as well, but that will be online.
Great.
So that's going to be, and they were going to make it like a kind of a certification, but now it's just going to be education because it's hard to get like CME for that as well.
Yeah, it is here too. It happens here too.
Yeah.
So Tara, I want to congratulate you on your work. Your webpage is great. It's so great, really. And hopefully you can get most of your material translated to Spanish someday so that we can all have access to that.
Yeah, well, you know what? It's interesting that you say that because I'm speaking in Mexico and I just submitted my slides that are going to be in Spanish. I'm talking about thyroid, estrogen detoxification, and just some case studies for menopausal therapy and monitoring. So they have to translate those slides into Spanish. So I'll see if I can get those. I'm going to be speaking in English, but they're translating the slides to Spanish for the participants. So hopefully I'll be able to get those slides and maybe repurpose them or something.
Yes, I can help you out with that. No problem.
Okay, great.
Okay. It's great to have you, Tara. Thank you so much for your time, really.
You're welcome.